Hello, I am Dr. Ballem. One of the common problems we see in our day-to-day practice is gallbladder disease. Perhaps as many as 20 million people in this country suffer from the gallbladder-related diseases, and most of them have the gallstones. About 500,000 of them undergo surgery because of it every year. In next few minutes, I will try and explain what the typical gallbladder problems are, why they occur, and what can be done about them. First, in order to understand what the gallbladder disease is, we need to know what the gallbladder is and what it does. The gallbladder is one of the digestive organs of the upper intestinal tract. These organs include the liver and its bile ducts, the gallbladder, the common bile duct, the stomach, the duodenum, and the pancreas. Bile is also an important ingredient in the process of digesting fatty foods. It is made continuously by the liver and is collected by the system of bile ducts for temporary storage in the gallbladder. When food enters the stomach, a chemical signal is sent through the bloodstream, causing the gallbladder to contract, much like a squeezed bottle. This forces the bile in the gallbladder out through the common bile duct and onto the intestine. Bile is normally a watery liquid with several different chemicals dissolved in it. These chemicals, including the cholesterol, give the bile the capability of helping in digestive process. The concentration of these chemicals changes for whatever the reason. Gallstones may then form in the gallbladder. These stones can take various shapes and sizes, ranging from a grain of a sand to as large as a hen's egg. The majority of gallstones look like these, which are smaller than a pea, or like these, which are almost as large as marbles. Often they are geometrically shaped like these, which are composed almost entirely of cholesterol. But the size and number of stones has very little to do with how much of a problem they cause. Changes in the concentration of bile chemicals leading to the formation of gallstones may occur for a number of reasons. One of the most common reasons is simply being overweight. Eating excessive amounts of fat and cholesterol also increases the risk. Gallstones are known to occur more commonly in the people who diet frequently and lose large amounts of weight. The major changes which occur in a woman's body chemistry during pregnancy can also lead to formation of stones. Finally, and perhaps most importantly, people whose family members have had gallstones have a significant increased risk of developing stones. In many cases, more than one of these factors play a role. When stones are present in the gallbladder, they may cause little or no trouble for years, but eventually they lead to what is known as a biliary colic or a gallbladder attack. The severity and length of these attacks can vary from person to person and even from one attack to another. In this diagram, several gallstones are present in the gallbladder. As before, when the food enters the stomach, a chemical signal is sent through the bloodstream, stimulating the gallbladder to contract. If a stone is pushed into the outlet of the gallbladder, an attack results. Typically, the symptoms are pain, nausea, vomiting, and occasionally diarrhea. While these symptoms are often severe, they usually resolve in few hours. In addition, even more serious problems, including common bile duct stone, may occur without warning. When the gallbladder contracts, a small stone may actually pass completely out of the gallbladder, usually accompanied by an attack of biliary colic. Once in the common bile duct, the stone can completely block the flow of bile into the duodenum. If this happens, the same symptoms of pain, nausea, vomiting, and diarrhea may occur, along with fever and jaundice as the bile backs up the liver. Inflammation of the pancreas, called pancreatitis, can also result from a stone in the common duct. When a stone is lodged in the common bile duct, urgent treatment is usually required. There are several treatments currently available for gallstones, two of which do not involve surgery. These two treatments are generally temporary measures which may be used in situations where the risk of surgery is too great. One treatment involves changing the chemical concentration in the bile, causing some gallstones to actually dissolve. Currently, a medication known as Actigall is available for this purpose. Unfortunately, this medication is effective only in small percentage of cases, and it may take several months to dissolve even very small stones. The other non-surgical treatment uses high frequency sound wave pulses transmitted through the body. This technique, known as lithotripsy, can sometimes successfully break up gallstones into small fragments which can then be passed into the intestine. Lithotripsy also has a limited effectiveness and is only used in selected cases. Following either the treatment with Actigall or lithotripsy, stones do reform, requiring further treatments. The permanent solution to the gallbladder problem would require removal of the gallbladder and the gallstones completely. This technique is known as a cholecystectomy and has been performed by surgeons all over the world for more than 100 years. The conventional surgical approach is to remove the gallbladder through an incision in the upper abdomen. Here you see the area of the abdomen where the gallbladder and the liver are located. During this type of surgery, the layers of skin, muscle tissue are divided and the gallbladder is visualized directly and removed. This incision is often quite painful, requiring hospitalization for 3 to 5 days, and it usually takes 4 to 6 weeks of limited activity to completely recover. Obviously, most people find that such a lengthy recovery is a major drawback to having this type of operation. Recently, another surgical approach was developed which is rapidly becoming the standard procedure for dealing with the gallbladder problems. This new procedure is called laparoscopic cholecystectomy. Again, we see the position of the gallbladder and the liver in the abdomen. For laparoscopic cholecystectomy, the first step is the insertion of the needle into the abdomen so that the cavity can be filled with carbon dioxide gas, much like inflating a balloon. This separates the internal organs from the abdominal wall. Next, instead of making a large incision, a small metal cylinder is placed through a half-inch incision in the umbilicus or belly button. A lighted tube called laparoscope is attached to a miniature television camera and is inserted into the abdomen through this cylinder. 3 more small cylinders are then inserted, which serve as passages for other surgical instruments. Using this approach, the gallbladder can usually be seen very clearly and removed. This is the image the surgeon sees on the television monitor during the operation. This abdomen has been inflated with the carbon dioxide gas and the gallbladder is identified. It is grasped by the assistant and lifted up to show the surgeon the important anatomic structures. The cystic duct connects the gallbladder to the bile duct, and the cystic artery is the main blood supply to the gallbladder. Sometimes a special type of dye is injected through the cystic duct so that an X-ray of the common bile duct can be performed. This may be necessary to ensure that there are no stones in the common bile duct. Once the X-ray has been completed, metal clips are placed across the cystic duct, which is then divided. Likewise, cystic artery is clipped and divided. The gallbladder can then be removed from the underside of the liver using either electrocautery dissection as shown here, or laser energy can be used as shown here. These techniques not only cut the tissue but also coagulate small blood vessels to prevent bleeding. When the gallbladder is free from the liver, it is removed from the abdomen through the belly button incision. If the stones are very large, it may be necessary to enlarge this incision slightly, but this does not prolong the recovery or add any significant pain. Laparoscopic cholecystectomy offers definite advantages over conventional cholecystectomy. First of all, the hospital stay is much shorter, usually less than 24 hours. Secondly, most of the patients are able to resume their daily normal activities, including exercise and returning to work in 5 to 7 days. Likewise, the postoperative pain is minimal, and surgical scars are less noticeable. This patient underwent laparoscopic cholecystectomy about 6 months before this picture was taken. As you can see, the visible scars are minimal at this point and will be even less noticeable after a year or two. In certain situations, laparoscopic cholecystectomy may have some limitations. If previous abdominal surgery has been performed, there can occasionally be such severe scarring inside the abdominal cavity that the surgeon is unable to see the gallbladder clearly. Or if the gallbladder is severely inflamed, it may be unsafe to remove it laparoscopically. Should significant bleeding occur during the operation, it may not be possible to control it without opening the abdomen. Or if a stone is found in the common bile duct, it may be difficult to remove it with a laparoscopic approach alone. In each of these situations, it would be up to the surgeon to decide whether the procedure could be completed laparoscopically or require switching to a conventional open operation. While laparoscopic cholecystectomy is known to be a very low risk operation, there are some potential complications. Because the general anesthetic is required, there are some associated anesthetic risks. These will be discussed with each patient by the anesthesiologist during a preoperative visit. Specific surgical risks include a slight chance of bleeding either during or after surgery, but only in very unusual circumstances would this require a blood transfusion or reoperation. Infections are possible despite the use of antibiotics, but they are unusual. Because laparoscopy involves placing instruments in the abdomen without the benefit of a direct vision, injuries to the intestine, urinary bladder, or even major blood vessels have been known to occur. During the operation, it is possible for the common bile duct to be injured or even severed. If this were to occur, it would likely require more extensive surgery to repair and could even lead to more serious complications. While surgery has some risk, for most patients, the likelihood of significant medical complications from untreated gallstones is greater than the risk of the operation. Most of the people have no problem adjusting to the removal of their gallbladder and find they can eat unrestricted normal diet. Almost all the patients will be able to leave the hospital within 24 hours after surgery. However, in the immediate postoperative period, it's very common to experience some nausea, abdominal discomfort, and shoulder pain. These symptoms usually subside after the gas in the abdomen is completely absorbed by the body. If the symptoms persist beyond a few days or a fever of 101 degrees occurs, the surgeon should be notified. Occasionally, a diarrhea can occur following indigestion of a large fatty meal. Usually, this is not a serious problem and can be avoided by simply staying away from large fatty meals. After 7 to 10 days, a single office visit is all that's required to ensure the wounds have healed, the recovery is complete. Today, laparoscopic cholecystectomy is the best treatment available to get rid of the symptoms of the gallbladder disease. If you have any further questions that have not been answered during this video or by the other written materials you have been given, feel free to contact our office at area code 201-744-8585.